North Carolina Medical Society is having their annual meeting on October 23rd and 24th. And it's at the Grand Nova Resort in Greensboro. And there are some CMEs associated with that. There is no registration fee, so it's just your stuff to get there.
All right, excellent. Okay. Oh, perfect time. Without further ado, I would like to introduce Dr. Lloyd Hey and also Rachel Griffin, and they're going to talk about scoliosis and kyphosis. I'll let you guys introduce yourselves. All right, thanks.
Good evening. Thanks for inviting us. My name's Lloyd Hey, and Rachel is my PA, and we're actually going to tag team the talk together. So we're going to give you a real good overview on scoliosis and how this could actually be something relevant for your own practice. And so we're going to start off by just giving a few words of introduction and then get right into the meat of it. And then we're actually going to finish up with a short quiz to kind of test your competency. And so our clinic, we're a small clinic, but we actually take care of patients over a very large geographic area across the southeast. We do scoliosis, kyphosis, spondylolisthesis care for kids, adolescents, and also adults. And so just a little bit about our background. In terms of our learning objectives, I was going to have Rachel give the meat of the talk because she knows this stuff just as well, if not better than me. And I'll finish up with some comments and will be available for questions and answers. So I'll let Rachel take it from here. Oh, okay. Actually, we'll go over a motivational slide. So one of the big things that comes up with scoliosis is that some people make it sound like it's just a cosmetic thing. It's just like, oh, don't worry about it. And I think that if you actually look back to some of the ancient texts, if you look at Hippocrates took care of patients with scoliosis and actually put a board in their back to try to straighten them out. That didn't work very well, but it hurt. But even if you go back to the Bible, Luke is a physician, and in chapter 13 in the book of Luke, he talks about a patient that came in not to clinic but into the synagogue here, and she can tell here she's got something bad going on. And maybe you've seen some patients like that in your own clinic. But basically what the story says is that she suffered for 18 years with basically severe kyphosis. And basically Jesus heals her, but when he heals her, she actually stands up straight and her pain is relieved. And so I think that this is a pretty clear case report, so to speak, from 2,000 years ago to show that spinal deformity is not just a cosmetic thing, but it can cause suffering. And so in our clinic, when I'm thinking about patient care, and Rachel, I have pediatric orthopedic training as well as adult orthopedic spine training. And so we see little kids that are 3, 4, 5 years old with congenital scoliosis, early onset. And so a lot of what Rachel and I are trying to do, and what Rachel's going to talk about, is the old stitch in time saves 9. So if this woman here, 2,000 years ago, if they had treatments, had been caught earlier, maybe even she was an adolescent, right, then maybe she could have been helped earlier and a lot less suffering would have occurred. And so a big theme of what we talk about is the importance of lifelong screening, lifelong follow-up, because usually you can prevent less suffering, basically, if you can catch things early and treat it early. So in terms of my own background, I got interested in this because at age 16, I didn't have scoliosis, but I had a really, really bad tibia fracture. And actually, this doctor here, Dr. Pittman, saved my life, but he also saved my leg. And you can see how I was missing like 3 inches of my tibia. And I had this external fixator on my leg that actually helped hold it together while it was healing after 11 surgeries, and worked very closely with Barbara Bader, who was an excellent physical therapist, and gradually was able to get back walking again. And actually my doctor allowed me to even do a little design of my own to help improve the design of the frame, so it actually helped it to heal, which actually made me want to combine engineering with medicine. So from there I went to MIT undergrad and studied electrical engineering, and stayed in Boston at Harvard for my medical school and my residency. And this is Dr. Hall. Dr. Hall was my main mentor at Boston Children's, and he's one of the founders of modern scoliosis surgery, one of the founders of the Scoliosis Research Society. And he wasn't putting on external fixators. he was putting in internal fixators, and going back to even the Harrington rod back into the 60s and 70s, but now it's progressed obviously a long way. And I saw him straightening up these kids, and it was miraculous. And so I was really, the engineer in me really just got hooked on that. So I ended up being his mentoree for several years while I was still there in Boston. And then I came to North Carolina about 21 years ago, where I met Peter years ago back at Big Duke. And I went there for a Duke Neurosurgery Orthopedic Fellowship. And rather than going back to cold Boston, where I had a job offer, my wife and I decided to settle here, and we've been here for 21 years now. So I worked at Big Duke for 10 years on faculty, and then about 10 years ago started Hey Clinic, which is an independent clinic, but we are located right next to Duke Raleigh Hospital. So I really want to do lifelong scoliosis care, and so we actually set up an independent clinic to do that. And then Rachel's been working with me for the past several years, and it's been great. But we do a lot of outpatient work, we do bracing, but we also do a lot of education, and we see patients from a very wide geographic area. Our patient from this morning is from Kentucky, but we also love serving patients around here as well. So we're big fans of TAPA. I've hired basically all of my PAs over the years through TAPA, which we appreciate. So anyway, we really appreciate you welcoming us. I'm going to let Rachel take it from here.
So as I go along, just stop me with any questions. I was telling Dr. Hay in preparing for this talk, I didn't get a lot of information about scoliosis, kyphosis, and other spinal deformities in PA school. It's kind of like you have a curve in your back, you have scoliosis, but that's all I got. So I've definitely learned a lot, and so like I said, as we go along, just stop me if you have questions, but we'll also take questions at the end as well. So the main deformities that we're going to talk about today is scoliosis, which like I said is a lateral curvature of the spine. It can be S-shaped or C-shaped. Those are the most common kind of shapes of scoliosis that we see. The next one is kyphosis, which everyone has a kyphosis. If you look at a spine model, if you look at someone from the side, their sagittal posture, this is your kyphosis and this is your lordosis. So everyone has kyphosis, but if you have an exaggerated kyphosis, which is anything greater than 45 degrees, then it can be problematic. We really don't worry about it until it's 60 degrees, but anything greater than 45 degrees is too much kyphosis, so to speak. And then the last one we'll cover is spondylolisthesis, which is a slippage of one of the vertebrae on another one. It can be either front to back or side to side. And so we'll discuss those things. So first, we're gonna, why does it even matter to talk about, scoliosis or kyphosis? Well, there's several reasons. It can affect your quality of life, your pain, your activities that you're able to do. Even kids as young as, 7, 8 years old are struggling with it. So it can affect that. Also, if you have a scoliosis or sometimes even kyphosis in the thoracic area, it can start to affect your heart and your lungs, and so your respiratory function and everything can be affected. And as Dr. Hay said, focusing on preventing future complications is really what we kind of do with education of our patients and also other healthcare providers out there. So scoliosis, these are two examples. You see the S-shaped and you also see the C-shaped curve. There's several causes, different causes of scoliosis. The most common we see is the adolescent idiopathic scoliosis, meaning it's coming on upon the adolescent growth spurt, so around age 12 to 14 for girls, 15 to 17 for guys. But there's also other causes, congenital, meaning there's something wrong with the vertebra. They can either be hooked together or they can be wedge-shaped, like triangle hemivertebra. Also, a lot of patients with cerebral palsy, other neuromuscular disorders, can also have scoliosis that go along with it. And with the genetics involved, it's really complicated. Only about 20% of patients actually can identify a relative that has scoliosis. So it's not always genetic. If you are a male, if your dad has scoliosis, you're more likely to pass it on than if you're a woman with scoliosis. There's been a lot of research being done in terms of the adolescent idiopathic scoliosis, looking at which particular genes are involved, and they've been able to identify a lot of them. They just haven't been able to kind of figure out how the puzzle all works together quite yet. So there's still a lot of research going on with that. And that, one of the main research groups is the Scoliosis Research Society, and it's not just research being done here in the States, but from all over the world that's putting that information together. So, important for us as practitioners, when we're looking at a patient, there's several physical exam signs that we can look for on patients. Now, you're not always going to have them, and sometimes, especially in the younger pediatric population, we get kind of fooled because they will have a hump on one side or something, but then we get an x-ray and it's nothing. But just in general, some things to look for are a thoracic or a lumbar rib hump. The ribs will obviously be in the thoracic area, not in the lumbar area. But right here you can see how this patient, when she's standing up, her ribs are actually kind of sticking out on one side. Okay. Another one would be this trunk shift. So both of these actually, they're brothers, they both have scoliosis, but his is a lot more severe, causing a trunk shift over to one side. And then if they have a higher curve, you're gonna look for the shoulder asymmetry. So one shoulder being higher than the other. Now, that's great for you to look at. Another screening tool that they have is a scoliometer. You can buy one of these, or they actually have an iPhone app. Now it costs like 99 cents. So if you have your phone on you can just pull it out. And basically what you do is you get the patient to bend over like they're touching their toes like that, and then you actually place the scoliometer on their back where you see that rib hump or the lumbar hump, or kind of in the thoracolumbar area. Anything greater than 5 degrees on that tilt gauge right there signifies that there's an underlying scoliosis. So at that point, then you want to get an x-ray to check and see if there's a scoliosis. Now, official diagnosis comes from an x-ray with a Cobb angle measuring greater than 10 degrees. So Cobb angles are kind of complicated to measure, but they have a lot of software that does it automatically now. So that's great. So, spinal deformity screening in adults. We showed you all pictures of kids, but adults you want to screen your adults as well. One of the misconceptions, and we'll talk about it a little bit, well, it's actually down here, is that a lot of adults will come into our clinic with their kids and say, I had scoliosis as a child, but I don't have it anymore. And we're kind of like, how do you know you don't have it anymore? Because that's one of the advances in the research that's been done, is it's not just a childhood disease. It's something that affects you throughout your whole life. And a lot of times what we're seeing now is, these 70, 80-year-old women and men who are coming in who are diagnosed with scoliosis as a child, haven't had any care, and all of a sudden they have really horrible stenosis, they can't walk, they're pitched forward, and horrible back pain. Well, their scoliosis went from a 23-degree curve to now a 53-degree curve over time. So that's one of the really important kind of take-home messages, is it's not a childhood disease, it's a lifelong disease that you can screen for at all ages. With those curves that tend to be collapsing over time, one of the key things that we hear all the time from our patients is, well, I used to be 5'8", now I'm 5'6". Or I used to, their height difference can change. And so that's something that if you pick up on that and you kind of notice one of those physical exam signs on an adult, then maybe think to get an x-ray and see if there is a curve underlying there. So, treatments for scoliosis. There's been a lot of research done about treatments, looking at, physical therapy, does that work? If we had them sit in a chair and kind of twist them this way, the opposite of their curve, for 24 hours a day, is that going to help? All of those have been proven insignificant. So there's kind of 3 levels of treatment that we talk about in our patients with scoliosis. Number 1 is just follow up. See what happens for the adolescent patients. We're following them about every 6 months to a year, depending on the curve and depending on their progression. So that's kind of the level 1, treating them symptomatically. If they have some back pain, we'll do some physical therapy or anti-inflammatories. That's level 1. The next option would be scoliosis bracing. And there's been a lot of research done over the years with bracing as well, which you all have a bracing article in your packet, and I'm going to discuss that in just a minute. That's considered for curves that are 30 to 40 degrees upon initial, if you're following them. But then if you first see a patient and it's 25 degrees, then you can brace them. But hopefully you will have referred them to a scoliosis specialist by that point, so you can discuss more in depth about it. And then once the curves reach 40 degrees or higher, no matter really the age of the patient, then we start to think about surgery. And the reason is because even if the patient has completed their growth spurt at that point, or they're an adult and it's not going to change. Curves that are 40 degrees or higher have been shown to progress over time, no matter where they are in their growth spurt or anything like that. So those are kind of the options for treatment. One thing I did forget to mention on the slide past when you're talking about screening for adults, in women, it's really important after childbirth and also during menopause or after they complete menopause to get checked again if they have scoliosis. Those are the other times in a female's life, besides that adolescent growth spurt, when the scoliosis has been known to change. So I talked about some of the conservative treatment for our adolescents, just being the anti-inflammatories and the physical therapy. For adults, though, we always treat them conservatively too, at first when we can. The conservative treatment, that includes physical therapy, as I said, a healthy weight. So for every 1 pound that you're overweight, it puts an additional 5 pounds on your lower back. So if you come in and you have really, bad back pain and you're overweight, a lot of our patients actually get better with losing that weight. Now we kind of get my back hurts, I can't exercise, so what am I supposed to do? Well, it's a combination, as we all know. The way you lose weight, it's a combination of you gain weight, really, it's what you put into your body and what comes out. And so you have to make a modification of food and exercise at that point. Also, low weight or light aerobic exercise is good. The stationary bike is really good for patients who have back pain. Also, anytime they can get in the water is really good as well, because it takes a lot of the pressure off their lower back, because gravity's not really there when you're in the water. Anti-inflammatories are great. And then also a lightweight back brace can be very beneficial for patients who have back pain and want to, do the conservative route. This is the bracing study that I was referring to. So it's actually a study that came out about 1.5 years ago that talks about the effectiveness of bracing. And it basically says that bracing is effective in 50 to 70% of the population when the brace is worn 18 to 23 hours a day. If you've never seen a scoliosis brace, you should have brought one, but it's a piece of hard plastic that you are Velcroed in. A lot of times mom or dad has to kind of cinch it around your waist in the back, and you can wear it under clothes and still look fashionable. But a lot of times for our 13-year-old girls, or guys, when we show them that, they're kind of like, yeah, no thanks, I'd rather not. So it's proven effective, but the compliance is the main thing that we have a problem with for the bracing. Also, kind of a limitation of the studies that have been done with bracing is the follow-up hasn't been lifelong. It's only been about 5 years of follow-up. And so we don't know what happens to the patients who were braced, 20 years ago. They wore the brace for 24 hours a day. We don't know what's happening to them now. So that's one of the limitations of bracing. So whenever we have a patient who's eligible for a brace, it's a big discussion with not only the patient, but the family as well. Because it's not a guarantee that it's going to do anything. And also, the brace does not correct the curve. It only stops any further progression of the curve. So if you have a 32-degree curve, the goal is to keep that curve at 32 degrees. So this is another study that came out recently looking at, they actually did MRIs on patients before surgery and after surgery, looking at the discs in the lumbar spine. As you can see right here with this curve, the lumbar spine is really affected right here. And those discs are pretty much just worn out. If you have a curve like that, there's abnormal loading on these disc areas right here, even as a teenager. And so what they did was they did MRIs of the teenagers before surgery and saw that the disc damage that was there, because you can see the discs on the MRIs. And then they actually took MRIs after surgery and found that there had actually been some improvement in the disc, which is we don't see that in our adult population. So that was really it goes with the whole philosophy of a stitch in time saves 9. So this is one example of a man that came in. He used to do a lot of manual labor. He came in, couldn't really walk anymore, and this was his back. So, now he's out, he can't do manual labor anymore, even after the surgery. But had we caught it, earlier, we could have saved all the discs in his lower back, or had it been caught earlier. 40 degrees or higher, we do consider surgery for it. This is an example of a patient, she actually has a 33-degree curve, which is less than 40, but she's got this really big 4-centimeter trunk shift. A lot of times with these trunk shifts, the patients are going to be in a lot of low back pain. They failed conservative treatment, so the physical therapy, the anti-inflammatories, and they have no quality of life even at 12, 13 years old. So this is the correction that we did. You can see not only is her spine straight, but that trunk shift is fixed. So she no longer has it. Also, you can see these bottom levels, which is the main, where your movement comes from in your spine, are these bottom levels. And we were able to spare those bottom levels because they were so healthy. I'll show you an adult one in just a minute, which is a little different. So this is an example of the same type curve as she had, but as an adult. So if you can see right here, her curve actually measures 68 degrees. She has, right here where this arrow is, this is kind of a close-up, but it's still hard to see, she's got a slippage. So she's got a spondylolisthesis slipping over. She's got a nerve pinch there as well. And it's really hard to see, it's hard to see on here, but her disc space is virtually gone right there. And so we cannot just straighten her up because she's going to have bone-on-bone rubbing below that. And so in order to correct her, we had to do a full fusion all the way down to the iliac joints. And so that does limit some of the movement that you have after surgery. So going back, if she had had it corrected as a child, we could have done a lot shorter fusions for the same results. So, as Dr. Hay had mentioned, as we've been talking about scoliosis, surgery, screening, the knowledge we have about it has changed over time. And one of the things that's changed is the Harrington rod. So this is just kind of a common scenario that we run into, and this is time for audience participation if you want to. But you have a patient that had a Harrington rod placement, which is this rod right here, in their teens. They're complaining of increased difficulty standing up straight, walking, and increasing lower back pain. So they're pretty much walking around like this, and they don't know why. They keep trying to pull themselves up, but they can't. The x-rays show that the Harrington rod hooks are in great position. So what's going on with the patient? Do we think it's a problem within the Harrington rod area? Above? Could be above. What about below? Below. Majority of the time, these patients actually have problems below. As I was mentioning earlier, everyone has these two curvatures of their spine. With the Harrington rod and prior fusions, they actually didn't bend the rod at all. They put them in completely straight. As you can see, once you straighten this is still curved on here. So there's a lot of pressure right here where that Harrington rod meets this lordosis. And so what we see is a lot of, we call it failure below the fusion, or flat back, because that lordosis is sometimes going like this to match up with the straightening of the upper back, all right? And so for these patients, there's still hope. We actually go in and kind of create that lordosis for them. That's changing as the evolution of spine surgery and deformity surgery has changed. We're now actually contouring the rods when we put them in the patient to give the kyphosis and the lordosis. So you don't have to worry about that anymore. Any questions about scoliosis? All right. So kyphosis is our next deformity we're going to talk about. And as I mentioned, everyone has kyphosis, but we get worried really when the kyphosis reaches greater than 60 degrees. All right. It can be, there are different, reasons for the kyphosis, which we'll discuss. A lot of patients, if they do have a more severe kyphosis, they're going to complain about neck pain and low back pain. Does anyone know why?
Because they have to put their chin up to look straight ahead.
Yeah. So everyone, if you look like this, everyone just has this natural curve. If you have an exaggerated curve like this, you have to lift up your chin, as you said, to look straight ahead. And so your neck gets real tired. An example we tell our patients is, all right, look up at the ceiling. I'm going to leave you alone for 2 hours and come back and let me know how your neck feels. You're all going to be in pain. And so that's kind of what a person with this exaggerated kyphosis walks around with every day. Another, the cause for the low back pain is pretty much the same. It's because you have this really exaggerated kyphosis, and right when it comes and hits the lordosis, it's kind of a sharp turn into this other angle. Okay? And so those are the common complaints that we get with the kyphosis. Right here, there's several different types of kyphosis. You can have post-traumatic, so if they have a compression fracture after an accident or just a vertebral fracture, that can happen. You can also get post-surgical, which is the picture up here at the top. You can see that that woman had a fusion, and the rod looks great, it's still in place, but she's collapsing above it. Okay, that's called, you can either have proximal junctional kyphosis or proximal junctional failure if it's more severe. You can also have what's known as Scheuermann's kyphosis. This is an actual vertebral body anomaly. So as the vertebral bodies were growing, mostly during the adolescent period, instead of growing in a rectangular fashion like they should, the anterior end plates just stopped growing. And so it goes like this. So you can identify it. This patient actually has the Scheuermann's. You can kind of see it looks more triangle shaped, several vertebrae do, instead of the typical rectangle shape that we see. And you can also get degenerative kyphosis, so you have really bad osteoporosis, you get some compression fractures. It ends up kind of following the same pattern as the Scheuermann's, where you just kind of collapse more. They're all treated the same, though. Kyphosis is kyphosis. Any questions about kyphosis? When we do kyphosis correction, we actually do the same surgical procedure as so if you look at someone from the front to back view, you would never know if they had kyphosis or if they had scoliosis. It's just the technique that we use when we're actually in the OR. We either correct it, side to side, or we work on kind of bringing the chest back when we're doing the correction. All right, so the last deformity that we're going to talk about is the spondylolisthesis, which, like I said, this is a slippage of the vertebra, either side to side or front to back. It can be genetic, or as a result of a pars fracture. A pars fracture, you can see it right here, it's the Scotty dog collars. I think it's the keyword on the board exam or whatever. But you can see right here, there's a fracture right there. That's a pars fracture. The pars is what helps to kind of stabilize the bone. So if you have a fracture of that, you're more likely to slip forward. Majority of the time, they're going to be bilateral if you have them, so it's just going to slip. Most common in our team patients are baseball catchers, gymnasts. Those are some of the common activities where you see a pars fracture. When you do have a slippage of the vertebra, you're at an increased risk for stenosis or nerve pinch. The reason is because if you look at the spine model, your nerves exit out through these neural foramen on either side of the spine. So right now, it's all perfectly in line and everything's great. But if one of those slips forward, then that nerve hole goes from being open to closed and closing off. So not only can it cause laterally stenosis, but also centrally it can cause stem stenosis, where the spinal cord and the nerve roots go at the bottom. So there's different grades of spondylolisthesis, grades 1 through 4. I actually have a picture of a grade 4, which we'll get to in a minute. But it's really important to follow a spondylolisthesis. A lot of times kids will be asymptomatic with them. And so, oh, don't worry about it, you just have a little fracture, it's not causing you any pain, don't worry about it. However, just like scoliosis, just like kyphosis, it can progress as you get older as well. So continuing to monitor the spondylolisthesis is very important, even through into adulthood. If a patient is symptomatic, a lot of times it is because of the pars fracture that's bothering them. So we'll start out by bracing, doing some physical therapy. The lightweight, just kind of Velcro. I always tell people it's like you see the people at Home Depot wearing or Lowe's, one of those type supportive braces can help. But occasionally we will do a molded brace, just in kind of the lumbar area for our patients with the spondylolisthesis or the pars fractures if they need more stabilization. If that does not work, their quality of life is still miserable, or if they have a pretty severe nerve pinch in both kids and adults, we will go ahead and fuse them. And so instead of the vertebra kind of going back and forth like this, because when they lay down, the vertebra falls back into the normal spot. But when they stand up, it flips forward. So what we do is we fuse it and make it so that it's not sliding back and forth. Keep it in one spot and make sure the nerve holes are open so there's no more nerve pinch. But there are conservative treatments that you can do. This is an example of one of the more severe spondylolisthesis. So you can see right here, his L5 vertebra is pretty much slipped off his sacrum right there. This is a grade 4. He actually had surgery done elsewhere, but it broke. And so it was still kind of sliding forward again. And as you can see his posture, he couldn't straighten up his legs or it was going to fall forward. So he had to hold himself up. And so we redid this and he's fine. Now, one thing that was kind of shocking to me when I first saw it is, well, if you look at this picture, if you look at the final product, he still has a really big slippage. Why don't you bring it back, or why is it not pinching it? There's a lot of risks with bringing it back to completely neutral position again. So the main goal is to stabilize it and make sure the nerves are not being pinched anymore. So if you have a patient, low back pain, can't figure it out, get an x-ray or MRI, CT scan, whatever, check for a pars fracture as well. No matter what spinal condition or spine condition you're dealing with, even if you don't know it's a spine condition, if you have a patient who comes in and presents with a loss of bowel or bladder function, progressive weakness, clumsiness, difficulty walking, or kind of progressive pain, the saddle area, numbness is a big one as well for cauda equina, which is a pinch on the spinal cord. But even if you don't have the saddle region numbness, you still have other of these, you could have a nerve pinch going on. So just don't forget it no matter what setting you're in. So some of what I want to kind of close on at the end was that a lot of our patients, you think of, oh my gosh, it's this big fusion in their back, they're not going to be able to do anything. A lot of patients prior, when they were just doing the hook instead of the rods and the screws fixation like we do now, they had huge restrictions after surgery where they were in a body cast for up to a year, on bed rest for up to a year. Our adolescent patients now can go back to doing whatever activities they want as soon as they want to do it. This is an example. It's actually the first patient that we allowed to do. I wasn't there, but Dr. Hey allowed to do. It was in 2005. She was a just below Olympic level swimmer and had a pretty bad scoliosis that was progressing. She didn't want to have surgery because she was told by other surgeons that she couldn't get back in the water. And when you're that competitive of an athlete, being out of the water for several months is pretty much bye-bye, career. So talked it over with her parents and they decided that, hey, you go back in and you swim immediately, or as soon as you want to. So 2 weeks after surgery, which is the time we want the incision to heal before you can get in any type of pool or tub or anything, she dove into the pool and swam a few laps. And so ever since then, all of our young adolescents, as long as they have good bone quality, they can get back to sports and everything immediately.
Are you including contact sports like football and wrestling?
Yeah, we would prefer them not to go back to football, the first 4 weeks, but they can get back on the practice field, be kicking, throwing the ball around, and everything like that. And there's several other exceptions if they have a really big curve or, something, but 99% of our patients can go back to sports. These are just a few of the patients. That was her in the middle going back to swimming. This was a volleyball player. She had a 57-degree curve 2 years out, still very active in volleyball. This was a golfer from Florida who was very concerned about his golfing after scoliosis surgery. So they actually set up like a mock putting green for him in the hospital. And he was playing golf in the hospital before he left. And then, after scoliosis surgery, Yes, this guy was bending. So as I mentioned, with the adolescents, we can spare those bottom levels most of the time depending on where the curve is. But that's where the majority of your movement comes from anyways. This is another one. She actually had kyphosis surgery. She had about a 90-degree kyphosis. And so she's a multi-sport athlete and is back to doing all those without problem. So just to kind of wrap things up, as we said, or as we've been talking about the whole time, care throughout the ages for any spinal deformity is really important. Starting with even, newborn checks, well not newborn maybe, but the first few months of life, sometimes you can even start to see the scoliosis forming and everything. Paying attention to the family history, but also not forgetting your 70, 75-year-olds who come in with back pain who were diagnosed as a child, but nothing pertinent over the past few years. They don't do school screenings anymore, which they used to do. So it's on us as practitioners to do those and kind of catch these things in the office. So now, are there any questions first?
You
Yeah.
don't pass, you don't eat. Sorry.
I used to do tons of sports physicals, and I would pick up on scoliosis, and the parents are really fixated on that form and getting cleared for sports. And hey, I just didn't know in general what recommendations were for scoliosis and exercise and group sports before any surgery, before any diagnostic whatever testing.
Yeah.
What are your thoughts on that?
So even if you have scoliosis, even if you have a 90-degree scoliosis, you can participate in whatever sports you want. So clearing them on a sports physical is fine. They can do whatever activities they want. Sometimes people will feel more comfortable if they're seen, and assessed by an x-ray or something, but they are free to do whatever activities they want. It's not, no activity that they're going to do is going to make it better or worse. Now, if they have something like a really bad slippage, one of the Spinalolisthesis, we may recommend holding off on some of the sports, but with scoliosis, you can do whatever.
I would agree with that. I think the other thing, though, is that just make sure that their neurologic exam is okay. That's more of an issue for the young kids. So there's a syndrome called tethered cord. So typically that would be in a younger child, but so some younger kids that have scoliosis, one of the reasons why they're getting their scoliosis is due to an undiagnosed neurological problem, and one of them is called the tethered cord. And in that case, the kids tend to walk a little bit funny. They might walk slightly wide-based, but that's typically not going to be a 12 or 13-year-old. It's going to be more like a 5 or 7-year-old. So they're typically not getting the sports physical. So still do a good neuro exam, but otherwise, as Rachel said, we do kind of see a lot of patients come to see us because it was picked up on school screening or on a sports physical, but participation in sports, just like Rachel said, is fine.
Do you know why they stopped screening in schools?
Money.
Funding.
Yeah, so.
I mean, how were they picking up a lot of scoliosis?
Yeah, great question. So there was a task force put together back in the 90s where basically scoliosis screening became very common during the 70s and 80s. And there's Dr. Coonrad in this area that was actually very instrumental in getting that going. But then by the time we got into the 80s and 90s, there was some concern about overutilization, like too many x-rays being ordered and so on. I think there's also some concerns about schools being kind of involved in healthcare, and what if they miss something or whatever. So I think there was some kind of political / legal concerns, plus some concerns about overdiagnosis or too many x-rays. So there's a United States task force that was created that basically said, well, scoliosis is not that big a deal, and we don't really want the schools involved, and so they stopped it. That recommendation came out in 1996. So pretty much since then it went way down. I think that it was almost like we went from one extreme to the other.
Right.
And I think one of the big downsides now is that the awareness, the good thing about school screening was it made everybody much more aware of scoliosis as a problem. And so I think we're seeing a lot more undiagnosed people showing up much later, especially from poor areas. I mean, like we see a lot of people from poor communities where they don't have great, health care like we have in the bigger cities. And so I think there's been sort of a backlash now. And that's where I think what Rachel said, that nights like tonight where all of us can be more aware as practitioners, kind of pick up on it, can hopefully make up for some of that.
Do you still find, so I worked for Dr. Coonrad, so when we were treating kids and they past puberty and their iliac crest fused over, we basically had the saying that if you stay under 30 degrees by the time you're skeletally mature,
Yeah.
there's not a great chance you'll progress in adult life. You're pretty good.
That's
And if you're between 30 and 50, you're in a gray zone.
gray zone, yeah.
And if you're 50 and above, it's likely that you will continue to progress in adult life. Do you still find that to be true?
Yeah, that's pretty accurate. I used to I shadowed Dr. Coonrad for a while. And actually helped him write up this series of 2,000 surgeries after he retired. And so yeah, I think that that's a good rule in general. But we do see curves that Dr. Coonrad pretty much only saw kids. I do both, and so I've been doing that for 20 years. So it's almost like I have a little bit different perspective because I've seen all those patients back, in fact, many of his. The bottom line is you're never quite out of the gray zone. So we have patients that only had a 10 or 15 or 20 degree curve. We have some adults that had no curve, but then end up developing a curve, during their 50s, 60s, and 70s. So that's why I think our whole idea with this is lifelong screening, lifelong follow-up is the best way, because that gives you the opportunity to intervene early, or at least if you have data over time with x-rays, you can at least then counsel the patient. So if they're feeling worse, and you have x-rays over 5 or 10 or 20 years that show that this curve is marching on, then it allows the patient to make a better decision. Whereas if we're just seeing a 60-year-old with one x-ray, and you guys know, you file vital signs and other labs, being able to look at lab values over time with measurements is very helpful. So that's why in our clinic we have our own custom electronic health record that we've built, where we actually take all of the old images and actually load them into our special database so that we can actually remeasure everything and see very accurately if it's progressing or not. Because they'll never be able to see it. The adult scoliosis typically only progresses at about a degree a year. So it takes many years typically to do that. But then what happens, once they get to a certain age, when the discs, as Rachel said, really wore out, then all of a sudden the wheels can come off the wagon and they can get 10 or 20 or 30 degrees of progression even within 1 year. And that's when they're really in agony. So we saw a patient from Dallas, Texas recently, 75-year-old who came for a second opinion from Dallas, a physician's wife, and her curve went from, she was in the 20s or 30s as a teenager, but basically went from somewhere in the mid-40s to over 75 degrees in just a couple of years, and then she could barely walk.
So then, if you're not a medical professional, how do you identify, aside from, chronic numbness or pain or lower back pain? I mean, I'm just wondering, if you're not someone who's a medical professional, but you come from a family of athletes, or you have a certain kind of job where it's very labor intensive, how do you know when you get to the point, okay, maybe I should get this checked out, maybe I should get an x-ray? Is it just like a degree of pain?
I don't know that there's actually like a set, time, this is when you should get it checked out. I think that if you have kind of that pain and everything we're talking about, the conservative treatment that we talked about is perfect. Whether you have scoliosis, whether you have one of those deformities, that's great to start with. If that doesn't help, then getting an x-ray is a perfectly acceptable next step. A lot of times, we see it from the pediatricians, the family care practices, along with the orthopedists, who are ordering the x-rays just because of low back pain, and kind of incidentally finding it on that. So there's no set, timeline. I'd say if you do have any of the progressive numbness, like, oh, it used to be my big toe, but now it's up to my ankle, or, it used to be to right here, now it's down to mid-calf, those are times when you want to get checked out. It could be, when you look up numbness as a differential diagnosis, you get a whole list of things. But I would say nothing else to add.
No, the only other thing is, as Rachel said earlier, checking your height over time. How many of you are in some sort of primary care specialty where you're seeing primary care patients? So when you're seeing patients on an annual basis, one of the things that's really helpful is to measure their height. So we all shrink a little bit, but just kind of keeping an eye on that. If somebody's having more than about an inch or more of height loss, you might want to look, make sure that you do the forward bend test as well. It might be kyphosis, it might be scoliosis, but height loss is a really good vital sign that we look for, and very often that will correlate with a deformity.
another scenario I'll tell you guys just from working with Dr. Coonrad. So again, scoliosis, when you're watching an adolescent, the time it tends to rapidly progress is right at puberty. So all these people coming into the office to see us, we had 10 to 13-year-old girls. And they would put a gown on and tie it in the back. And he would stand the patient in front of him with the back to him. And he would go up to them and untie their gown and tell them, I'm going to drop this on the floor. So you had a lot of very shy young ladies freaking out. However, when you see what you can see when someone doesn't have their clothes on, as far as seeing the change in the scapula, shoulder elevation, if somebody has the truncal decompensation where they're shifted over, one hip sticks way out, when they have that kind of stuff, you're also getting the folds on their back. Somebody might have one crease and then two on the other side. So if you're in family practice and you're looking at a little kid, you really do need to sometimes take all the clothing off, because the style now is to wear something that's 10 times too big for you to begin with. You know, if they got a dry fit shirt on that's very form-fitting, you're cool, but if the kid comes in and you don't bother to look at them and they're wearing a 2XL shirt and they're 10 years old, you're going to miss it.
The other thing that's becoming more of an issue too that goes along with that is, for those of you in primary care especially, the incidence of obesity has really hurt us in terms of scoliosis, because we see some kids coming in with kyphosis and scoliosis where you never know it, and they can hide a really big curve. So the increase in obesity in both kids and adults is making it tougher to see those deformities. I have seen Dr. Coonrad actually have kids take their clothes off, and I will tell you that's something we don't do. I just didn't feel comfortable with it. I love Dr. Coonrad, he's a great guy, but so what we do is, in a very discreet way, we will peek and so on, but we don't make them get completely undressed. So we do think about that. So while you guys are eating, just to prove your scoliosis, kyphosis, deformity competency, we're going to have a little bit of a pop quiz, okay? And this will be something that will be a little bit fun, but I'll make sure that we all learn something tonight, and then we can enjoy dinner. I'm going to let Rachel eat, and I'll go over the quiz with you, okay? Okay. So why don't you give me a copy of the quiz as well? Uh-oh, Rachel changed the quiz. I may not know the answer to that.